Hello and welcome to today's webinar organised by the Ophthalmologist and ODOS. My name is Mark Hillen, I'm the editor of the Ophthalmologist, and it's my great pleasure to be the moderator of today's online event, which is titled Navigated Laser Therapy, Moving into Clinical Practice. So please allow me to introduce today's speakers, Professor Souied, Dr. Francesca Amoroso and Dr. Alexandre Pedinielli. Even in the age of anti-VEGF therapeutics, laser maintains its essential role in the comprehensive management of retinal disease, in reducing DME treatment burden and managing non-responders, and as a first-line therapy for proliferative diabetic retinopathy and other conditions. Image-guided navigated laser systems have been introduced to replace the manual operator-dependent techniques, designed to produce a better quality of care. This webinar aims at educating physicians about modern-day laser treatment planning and its use in teaching and treating anti-VEGF refractory retinal conditions. Today's webinar is all about learning from these experts and about modern-day laser treatment planning and its use in managing a number of retinal diseases. So, one little fact here, Professor Souied was one of the first users of pre-planned pan-retinal photocoagulation in clinical practice, and he'll be the first speaker today. The speakers will be on hand at the end to answer any questions you may have, but please remember that you can submit questions at any time throughout the webinar. We'll also be asking you some polling questions and displaying the results live, so please do get involved. So, here is the first set of polling questions. 1. Are we going to need retinal laser treatment in the future? 2. How many laser treatments, focal PRP or retinopexy, does your clinic perform per week in total? And 3. Are you using microsecond or subthreshold laser, or are you interested in using it in the future? Okay, thanks. So let me get today's webinar underway by passing you over to Eric. Eric, over to you.
Good evening. My name is Professor Souied, head of department at the Crete University Eye Clinic. Together with my brilliant colleagues, Dr. Francesca Amoroso and Dr. Alexandre Pedinielli, we'll talk today about the navigated laser therapy and moving into the clinical practice. This new approach gives us a real revival of the laser therapy, and we'll go through some examples all together. There is still an important role for the laser, even in the age of anti-VEGF therapy. Today, physicians use laser first as a rescue therapy if DME persists after initial anti-VEGF. It was shown in approximately 50% of the patient in the protocol T. 50% of the patient benefit of laser therapy, even if they had anti-VEGF treatment. But secondly, the laser is performed in combination with anti-VEGF, not in rescue therapy, but a priori in many patients. It was in the RESTORE and READ study. Laser is used as monotherapy for non-central DME. It's used for proliferative diabetic retinopathy as first line and many other indications than diabetic retinopathy. There are different kinds of laser, focal laser for DME, CRVO, BRVO, microaneurysm, neovascular ND, micropulse laser for CSR, DME, or peripheral laser for PRP, peripheral degeneration, or peripheral vascular lesion. The Navilas give us a real new way to perform the laser that is a smart way. First, because it's a contact-free laser, because we have an infrared illumination, it's an intuitive and really a plug-and-play use of the laser with smart control of the laser. This is really convenient for the user, for the physician that do that. But for the patient, the benefit, what it brings for the patient, first, it's accurate for navigation with planning and eye tracking. We can compare it with a robot because it knows exactly where it should do the laser really precisely. There is less pain. That is also a big advantage for the patient with short exposure, contact-free in focal application. And this is really a fast laser approach with pre-plan in PRP as well, eye tracking for shorter patient interaction time. There are many, many advantages, and probably the more important for the patient is the safety that it brings. So I will now give the microphone to my colleague Francesca Amoroso that will talk about peripheral navigated laser.
I'm Dr. Amoroso, and I'm glad to present you the clinical application of Nevilas for the treatment of the periphery of the retina. As Professor Souied previously showed, with Nevilas we could easily treat diabetic retinopathy, central vein occlusion, but also peripheral vascular lesion as sickle cell disease and peripheral degeneration. But which are the advantages of the PRP performed by Nevilas? First of all, is a fast treatment, but also is a comfortable treatment for the patient with the infrared option. Also is safe and precise with the possibility of the pre-planned treatment option, and above all, is a painless treatment. Now I will show you how to perform a Nevilas for a PRP treatment of a diabetic retinopathy. First of all, I will put the Meister lens on the eye. I take a color fundus picture, as you can see in the video, and after I plan the treatment, putting the caution zones on the optic nerve and on the macular region. So I start to draw the area that I want to treat. And after, I will start the treatment. So you can see how it's easy and fast. You can see the whitening of the spots. And at the end of the treatment, we take a curve, a fundus photo picture to see the whitening of the spots. Now I can start to treat another zone. So I will start to plan the treatment for the inferior quadrant. I put the caution zone on optic nerve and the macula, and I draw the region that I want to treat. So it's very easy, and I start treatment. It's very, very fast. You can see the whitening of the spots. So the efficacy of the treatment. Now we end the treatment with a color fundus photo to be sure that treatment is complete. Here you have the report of the delivered spots. We treated 2 quadrants in same session with 1,304 spots with 330 millivolts, 20 milliseconds, and 390 for the spot dimension. Recent study showed that the PRP treatment performed by the Nevilas is faster, painless, and has a better clinical efficacy than conventional lasers. And here I will show you another treatment of a patient with a mid-periphery retinal hole. He's a myopic patient. You can see how easy it is to take the picture, draw the zone that I want to treat, and start the treatment. So it's very easy and very fast. And I will conclude with a color fundus photo for. But with Nevilas, we can also treat the peripheral region in the extreme periphery of the retina. Here you can see a case of a lattice degeneration that we easily treat by Nebulas. And I will conclude with the last case of a young patient with a sickle cell disease. The advantage of the Nebulas is that we have the possibility to import fluorescein angiography images. In this case, we import the fluorescein angiography performed by the Heidelberg angiograph, and we obtain an hybrid image overlapping fluorescein angiography and the color fundus photo to treat exactly the retinal neovessel and the adjacent ischemic zone. Here you can see the wonderful results after treatment. In summary, the advantages of the purple-blooded PRP: evenly spaced spots instead of disjointed grids, rapid spot delivery, great overview due to large field of view, complete documentation of the entire treatment, and the possibility to use wide field fluorescein angiography to get treatment. Thank you.
So, hello everyone, I'm Dr. Alexandre Pedinielli from Créteil Eye Clinic, and I'm going to talk about macular treatment using Navilas. So, as you saw earlier, laser using Navilas is fully digital. To perform laser treatment, you need to take a digital image of the fundus, then plan the treatment you want to perform, either directly based on the fundus photo, or you can first import any image you want, like thickness mapping, for example, and then you can plan your treatment based on this image. After the treatment, you'll have a precise report of your treatment to remind you exactly which zone you treated and with which parameters. So as I said, you can overlap any image you want on the fundus. It can be a fluorescein angiography, it can be ICG, it can be mapping, and actually it can be anything else. So this is the video of a patient with advanced and active AMD. Her visual acuity was less than 2400 for years now, but her new vessel was still very active, and her central sclerotoma was actually growing. So we performed an ICG to localize the new vessels, and especially the feeder vessels, and we imported this ICG into the Navilas. We overlapped the ICG on the fundus image, and we selectively treated these feeder vessels. This was to treat the activity of the new vessel without injecting anti-VEGF every month. So as you see, the treatment is made very quickly without using any contact lens. We can even do the treatment on the infrared image to prevent the glare. And even if this patient had a poor fixation because of a sclerotoma, the eye touch-it system worked perfectly, and we were able to treat exactly the zones we wanted. So there are many clinical applications of focal lasers. Advanced AMD, as I showed in the video, but also microaneurysm, macular edema caused by diabetic maculopathy or vein occlusion. And this list is actually not exhaustive, because you can treat almost any exudative disease you want. You can also treat polyps, CSC with extrafoveal leakage, and probably other diseases. But let's talk about these ones first, and I'll show you some cases. So this is the case of diabetic macular edema. As you know, you can treat focal edema using a foveal grid, but this kind of treatment usually leaves multiple scars on the macula. So our approach is to treat only and selectively the big microaneurysm responsible of the edema without touching the RPE with the laser to prevent the scars. The ICG is the best exam to localize precisely these aneurysms, as you can see here. So we overlapped the ICG and the fundus photo, and we treated only these microaneurysms. That's the fundus photo after the treatment. You can see the whitening of the microaneurysms. Here you can see the OCT before and after the treatment, and you can notice that the laser selectively treated the microaneurysms and didn't touch the RPE at all. And that's the mapping 3 months after the treatment. Of course, with this approach, we only treated the temporal inferior focal edema. And you can see that this part of the edema really decreased 3 months after, whereas the rest of the edema, and especially the central edema, remained refractory to the anti-VEGF injections. Now, that's the case of branch vein occlusion. You can see that the big microaneurysm is very well seen on ICG, but not at all with fluorescein angiography. So once again, this highlights the importance of performing ICG in microaneurysms. And so we treated this aneurysm after overlapping the ICG once again, and thanks to the report, we know exactly what we did. We used a total of 15 spots because the power we started with was too low, and we treated it 3 times with a final power of 100 milliwatts using the 120 milliseconds pulse durations. Now look at the results. 3 months later, without any other intravitreal injection, the central edema completely disappeared, and when you look at the mapping, you can see that it really decreased thanks to the treatment, and once again, that was without any other intravitreal injections. Now, this is a case of arterial macroaneurysm, which is perfectly visualized with both angiographies, but the localization is probably better with ICG because of the lack of diffusion. So the aneurysm is also very well seen on OCT, as you can see here. And we also treated it several times, increasing the power each time because we didn't want to hit it too strong. So we performed 22 spots for this microaneurysm, but it was almost only a pattern of 5 spots. So that is what it looks like after the treatment. You can see the whitening of the microaneurysm. This is the OCT before and after the treatment, and you can notice the complete hyperreflectivity into the aneurysm after the treatment, showing its occlusion. And this is the mapping 3 months later, showing an almost total resolution of the edema. So it works quite well. That's another case of advanced AMD with a fibrovascular lesion causing the central scrotoma, which is responsible for a vision under 2400. And you can see on the OCT the new vessel is active with a temporal macular edema, and we didn't want to keep injecting every month this old patient who didn't have any chance to increase its vision. You can see the neovascular plaque is very well visualized on ICG with a nice feeder vessel, and on FA you can see there's a temporal diffusion as well. So we treated the temporal branch of the feeder vessel because it was the active zone. Of course, the treatment was based on the ICG we overlapped, and this is the picture of the report showing exactly which parameter we used on each zone. So that is the result 1 month later. We performed another ICG, and you can see that the temporal branch of the new vessel is completely occluded, and we were actually happy with the results, as you can see here. Fortunately, the macular edema didn't decrease, and that's because a type 2 new vessel developed in the temporal part of the occult lesion. We are currently treating our patient like this, and we are trying to figure out how to prevent that from happening. That's another case of advanced AMD with a wide fibrotic new vessel, but this time the new vessel was inactive, but there was a secondary polyp that you can see on ICG which was active. So that's the report. We treated it based on the ICG, and you can see the parameter we used. This is the OCT before and right after the laser treatment, and you can see that there is a total hyperreflectivity inside the polyp after treatment, showing that it has been occluded, and that the laser didn't hurt the RPE around it. This is the OCT 6 weeks later. The edema disappeared and the macular thickness decreased, showing that the treatment was successful. So you can see how many things you can treat with focal lasers, And once again, this is all fast, very precise, painless, and without any contact lens. Now let me show you a few cases using microsecond pulsing treatments. Microsecond pulsing has fewer clinical applications, but it can be very useful when needed, especially with CSC, but also for macular edema. The principle is to prevent scarring using a series of very short microsecond pulses, which will only photostimulate the RPE instead of photocoagulate it. This is a case of CAC with a leakage point close to the fovea. Fluorescent angiography was overlapped to localize the zone to treat. We planned the microsecond pulsing treatments. We titrated the power in the extramacular zone right now to find the power causing the small whitening of the retina. Then, once we got the power to whiten the retina, we took only 30% of this power to treat the leaking zone. So I don't have the follow-up here, but the subretinal fluid completely disappeared 1 month later. But everyone can say that in any CSC there can be a resolution by itself, and that maybe the laser wasn't the cause of the recovery of the retina. So let me show you another case. This is a patient with a refractory CSC due to Cushing syndrome. We have been following him for years, and there has always been a refractory subretinal detachment even after PDT. There wasn't any sign of new vessel on the CTA. We couldn't treat him with eplerenone because it would imbalance his general treatment. And the subretinal detachment decreased after PDT, but PDT caused the macular atrophy on the other eye, and we really didn't want to take the risk on his good eye. So we treated the leakage zone with microsecond pulsing. This is the report of the treatment. You can see that the leakage zone was quite wide, and we didn't really believe in the treatment would be successful in this case because of the history of the patient and because there was not really focal zone to treat. That's another image of the report showing exactly which power we used in which zone. Now look at the results. We treated him in June. The subretinal fluid decreased a lot 2 months later, and 4 months later the subretinal fluid had completely disappeared like never before. So in this case we really believe it's not just a fluctuation of the activity of the disease, but that microsecond pulsing really works. So to sum up, focal treatment using Navilas can be used for almost any macular disease. It's precise, safe, easy to use, comfortable for the patients. So we really believe it's the new generation of laser. It's really an armed robot, and the nickname I give him is the Terminator. Any questions?